Okay guys, we're talking about pulmonology. The lecture today is really important. I think you might get a few questions in the USMLE from this. This lecture is about the flow, pressure and resistance relationship. So the topics that we'll cover, we'll look at the definition, we'll look at the formula or equation for the flow. We'll also look at the equation for the resistance, the Poiseuille's equation or Poiseuille's equation. We'll then look at the airway and see where the actual resistance in the airway comes from and how does that resistance change. That is what is the clinical part of it. It'll be used for asthma. You'll be able to make use of it for the patients who just inhaled, let's say, smoke or smog or hot air during a fire or something. Then we'll look at the factors that will be affecting the resistance, and we might even solve a small problem that might come in the USMLE exams. So let's start. First of all, the flow is defined as it's the ratio of the pressure gradient and the resistance in the system. What does that mean from airways point of view? We know that cardiovascular we use this term. How does it apply in the airway? So look, the pressure gradient is between the pressure difference from the mouth and nose to the alveolus. So this pressure difference between these two, here and here, this pressure difference is the delta P that we use. And you know from our other lectures on pulmonology that this pressure difference normally is very tiny to make the differences. For example, we know that the alveolar pressure goes to -1 centimeter of water, just -1 centimeter of water, and 500 milliliter of air goes in. So flow is so much that just by -1 centimeter of water change, 500 ml of air can flow in. It does take about 10 to 12, 13 seconds. Lungs slowly expand, but that is the amount of air that can go in. So 1 centimeter change can bring in a lots of 1 centimeter of water change of alveolar pressure. Alveolar pressure. Can cause a tidal volume to move in or out. So keep in mind that. So that is the pressure gradient. Resistance is the resistance of the airway. That is what is important. You are going to, just like you're going to see the patients with the hypertension and the patient with the cardiovascular problems, you are going to see patients with the asthma. You are going to see patients with the respiratory problems. So pay attention to this one, and unfortunately smoking is very common, so you'll also see the patients who have emphysema with the smoking, and so pay attention to this one. Look, resistance of the airway, the first thing to note is this. We talked about it in cardiovascular system. The Poiseuille's equation is that resistance equals a constant times the density of the fluid times the length divided by pi r4, where radius is the primary factor. So normally we say that the resistance of a tube, resistance in a tube is really dictated by the diameter of the tube. Here in the case of airways, the diameter, think about it, be with me for a second. Diameter of the airway, nose and mouth is a large diameter, right? Then trachea is very large diameter as well. The diameter is large here, large in the initial bronchi. Then we know that the division of the bronchi occur towards the medium-sized bronchioles, then terminal bronchioles, then respiratory bronchioles, and then alveoli. We have done that in the anatomy lecture, in the structure of it. The important thing here is that if you look at the Poiseuille's equation, that says that the resistance in the smaller diameter is increased, right? It is inversely proportional to the diameter radius raised to the power 4. However, in the lungs, so is the case in the cardiovascular system as well, the resistance in the smaller airways is actually lower. There are two reasons for that, and resistance in the bigger airways is actually higher. Again, same two reasons. What are the two reasons? This one you have to master, because this is a paradoxical situation. Paradoxical situation is, what we are saying here is that the resistance in the larger airways with the bigger diameter is more than the resistance in these areas with the smaller diameter. So that's paradox, right? And it does not fit the formulas here. So let's explain it. We did that for the cardiovascular system as well. First part of the explanation is this, that because the smaller airways are all laid out in parallel, so this is really a division of the, or addition of the resistance in parallel, and the parallel resistances are summed up by their inverse. So total resistance in a parallel system, R is equal to 1 over R1 plus 1 over R2 plus, we keep going till 1 over Rn. Remember, so this actually reduces the resistance. Another way to understand this is that the collective diameter of all the small bronchioles and small respiratory bronchioles, if you collect them all and put them together, they make a very large pipe. So resistance in that very large pipe, of course it's a huge diameter, then that would be really low. For example, in the cardiovascular system, we said that if you collect all the capillaries and put them together, they would probably make about 6 meter wide pipe. So back here, this is one reason. Second reason, which is also important, is that in the larger diameter vessels, the turbulence is more, and because of higher turbulence, it is difficult for air to move. So there is increased turbulence here, increased turbulence. And why is there increased turbulence? Look at the Reynolds number. Look at the Reynolds number. What does it say? The Reynolds number says that based on the density, diameter, length and viscosity, you can create a number, and if the number becomes higher, then the chances of turbulence are higher. So in these areas, the diameter is high. The viscosity of the air is almost the same everywhere. So because of higher diameter, the chances of turbulence are bigger in here. So due to that, the resistance is more in the larger vessels. So these are the two factors. One, parallel resistance, and number two, the turbulence is more in the larger sites. So in the USMLE, you might see a graph that would look like this. It would look like this, at starting from the nose and mouth, and then trachea and big bronchi, and finally mid-size bronchi and bronchioles, and then small terminal bronchioles. Question is going to be, where is more resistance? And you might be given A, B, C, or you might have a chart or graph that you have to select. So look at this, 50% of the resistance is offered by the mouth, nose, trachea and large bronchial system. Another 30 to 40% is by the mid-size alveoli. This is where the maximum actually the resistance is. So resistance goes up like this, and then it goes down like this. So it's slightly kinked here. So what happens is, what we're seeing is sorry, got to make it a little more accurately. So here it would start going up. In the mid-size bronchi and bronchioles, it is maximum, and then it starts falling for the smaller airways. So the maximum resistance is present at the mid-size airways. They offer the maximum resistance, not the terminal airways. There is one more factor in the terminal airways, which is actually related to the second factor. Second factor was that turbulence is higher in the larger bronchi. Similarly, turbulence is lower. Laminar flow is higher, or the flow is laminar in the respiratory and terminal areas, bronchioles. Why is that? Because their diameter is so small that they only allow very small amount of blood air to pass. Okay, got it. So that is the relationship of resistance and why the resistance is higher in the bigger vessels, in the bigger airways. So now let's see what are the factors that affect this resistance. What are the factors that would change this resistance? What we have to keep in mind is pressure is almost going to be the same. The pressure between the alveolus here and the mouth and nose, that pressure gradient is going to be the same. So keep that as a constant. It is the resistance that is going to change. So what are the factors that change the resistance? So before doing that, let's look at quickly the structure of the bronchi and bronchioles. So the structure is, it's a pipe that has internally, of course, the epithelium, right? It's an open system. It communicates with the outside. So it has epithelium on its surface, right? This epithelium underneath has smooth muscles and glands. These glands are the ones that are the culprits in case of asthma, right? Where they secrete stuff and cause mucus plugs. Plus they proliferate and they squeeze the wall. So there are smooth muscles, these red ones. There are glands here, and if you go to the larger areas, then there is the cartilage as well, right? So let's say this is a piece of a cartilage. If you cut it and see, this is another cartilage. So cartilage, glands, smooth muscles. These smooth muscles are the culprits. These are the ones that we need to understand a little more now. Look, these are all the smooth muscles. They are present around the airways, and they can squeeze them and reduce the diameter, or they can relax and increase the diameter. As the diameter would reduce or increase, resistance would increase or decrease, and that would increase or decrease the flow. And believe me, ask a patient with asthma that this change in flow is so dramatic, and this change in flow is so threatening that the patients actually they become nervous and they become anxious, and it's really terrible to experience. So let's look at what causes these smooth muscles to change their tone and then cause increase or reduce of the diameter. So let's start. First of all, there are local factors. Local factors are two primarily. Number one, mast cells that live here. So mast cells that live here. Mast cells also live here in the alveoli. Mast cell can release the inflammatory substances, chemokines. So mast cells release substances. These local substances can work on the smooth muscle and cause constriction. There are also substances, for example, histamine and slow an anaphylactic substances, slow releasing substances of anaphylaxis. These are also the substances that are released by the inflammatory tissues once the allergic reaction happens, and these inflammatory cells, and these substances actually start releasing after 24 hours, and they're formed new and then released, and when they are released they act on the smooth muscle and they constrict them. Now keep in mind, in the context of this lecture, when the smooth muscle would constrict, the diameter would reduce. When the diameter would reduce, if you come here for a second please, when the diameter would reduce, radius will reduce, that would increase or decrease the resistance. Reduced radius would increase resistance. Increased resistance would reduce flow. This is the dots you have to connect, that when the radius changes, change in radius is going to reduce the resistance or increase the resistance. Change in resistance is going to change the flow of the air through the airways, and that is what is the pathology or absence of it. So local factors, slow substances of anaphylaxis and histamine. Then irritants. For example, smoke. Smokers really do a number on themselves. Smoke, smog, there are substances in smog that cause irritation. Then other substances that are present in the environment, for example asbestos and other things, they can come in, they can irritate, and the result of irritation of the layers is going to be, number one, release of the inflammatory substances, and number two, release of the mucus and other secretions to remove the irritation, and that would start plugging the system. And when the system is plugged, when the pipes are plugged, it is difficult for the air to move and resistance would go up, right? So that is the irritants. Then most important, autonomic nervous system. Do you know that these irritants work in two ways? One is that they directly act on the smooth muscles and cause them to constrict. Second is they act on the parasympathetic nervous system and increase its firing as well, or its stimulation as well. So autonomic nervous system of course has two parts, parasympathetic and sympathetic, right? Parasympathetic, what happens is vagus nerve gives nerves off that penetrate the parenchyma, reach the bronchial muscles and supply them. Very sparse, very less. However, acetylcholine, when it is released from the vagus nerve, that would cause, what will it cause? So if this is the vagus nerve, acetylcholine release will cause constriction of the smooth muscles. Similarly, sympathetic system doesn't have a lots of nerves. There are not lots of nerves that are penetrating the parenchyma. However, the muscles here have receptors for epinephrine and norepi, which are sympathetic chemical substances. Once they attach to beta 2 receptors, remember, one heart, two lungs, beta 1 in the heart and beta 2 in the lungs, bronchiolar systems. So beta 2 receptors, when they are stimulated by the epinephrine and norepinephrine, that causes the smooth muscles to actually relax. The same effect as on the cardiovascular system as well, vascular systems too. So sympathetic system would increase the diameter and so increase the flow by reducing the resistance. Parasympathetic system reduces the diameter. Reduced diameter would increase resistance, that would reduce flow. Irritants also stimulate parasympathetic system. They directly act on the smooth muscles as well and damage it. Then what else? What are the factors you are seeing there? So you are seeing the factors, there is density, there is radius, there is length. So how about the density? Density of the air. This is only useful when you talk about the deep sea diving, where the air density increases and so the resistance to flow also increases. Or if you inhale helium, Helium has a very low density compared to the normal air we breathe, and so the airflow increases. And then how about the lung volume? That is the most important thing that we should pay attention to. That is lung volume. So you say, hey, lung volume? What is the role of the lung volume with the airway resistance? So here is what it is. Let's make that here. Let's say this is an airway. This is an airway. The lung is filled with alveoli, right? Alveoli that are present near the airways. So let's say this is the cluster of alveoli. This is another cluster of alveoli. So of course, primarily there are alveoli in the lungs, right? These rounded structures that are surrounding the airways. So imagine if this is the airway, it is surrounded by the alveoli which are connected to other alveolar sacs which are connected to some other bronchioles. These alveoli like this, if these are the alveoli and this is a bronchus, the alveoli are touching it. Now what is the benefit of alveoli touching it? And imagine if they are touching it on all sides. What is the benefit of that? Look, what do alveoli want to do? They want to collapse, right? They want to recoil. But these alveoli, if I make one big one over here to show you, this alveoli, it wants to collapse because of elastin and collagen present in it, in its walls, but this alveolus is also anchored on with the surrounding tissue. So when the alveolus tries to collapse, it has a traction on the airway and it pulls it open. This is called, I'm going to write it down over there, this is called radial traction. This is called the radial traction exerted by the alveoli on the bronchial pathways. Now imagine a patient who has a problem with the alveoli, emphysema. Somebody who has been smoking for the whole life has caused a damage to the alveoli, or the patient who have infections or allergies or repeated damage. So the alveoli are now broken, their septums are weak, their elastin and collagen are weak, they are less kinked, they are less springy, they are less pulley. So now what happens, or the person is aged, age also does this. Now what would happen is these alveoli will not pull the airways out with enough force. And what would happen to the airways? They would start collapsing. So the airways are now collapsing because alveoli are damaged and they are not causing radial traction. So when they are not causing radial traction, lungs start collapsing. So this is what can happen in the patients with the emphysema and patients who have damage to their alveolar system. So this is the flow, pressure and resistance. Important thing to note here. Let me do a quick math for you. Imagine that there is a patient that has pressure of gradient of 16. So I said that just one is enough, but let's say there is a gradient of 16 and the resistance, let's calculate that separately. Let's say that patient has the density of 16 of air, length of the tube is 1 centimeter. Let's ignore 8 and pi, they are constants. Radius is 2 millimeters. I'm just making up some numbers. So let's calculate it. 2 raised to power 4 is 16. So 16 divided by 16 equals 1. If you put this 1 down here, then the flow is going to be 16 centimeter, let's say, per dyne of resistance. Now let's change the radius. Let's change the radius by half, make it half. So instead of 2 millimeter, it becomes 1 millimeter. What would that mean? That would mean 16 multiplied by 1 divided by 1 raised to power 4, which is equal to 1. So that is 16 divided by 1 is 16. Plug that value underneath here. 16 divided by 16 equals 1 centimeter per dyne. How much is the difference you are seeing? You are seeing 16 times the difference. Reduced airflow just by reducing the diameter by half. So imagine a poor asthmatic patient who has his airways reduced in diameter due to extra secretions from the glands, due to chronic inflammation, and due to proliferation of the muscles and the tissues in the airways, and then presence of mucus and plugs like that. So that patient would have a huge reduction in the airway flow. Then imagine that patient having parasympathetic flow on top of asthma. Now what is happening is parasympathetic acetylcholine is going to further increase the tone of the bronchial muscles, increasing or exaggerating the problem. So this is what happens when the resistance changes, and in the case of lungs it is really, really important for you to be able to understand. Number one, do this math, and number two, keep these factors in mind. Thank you very much.